Hi, this is Brian Wormers recording a lecture on musculoskeletal disorders for medical surgical nursing at the University of Sioux Falls. So talking about some of the learning objectives with this, we're going to assess patients with musculoskeletal problems, identify priorities for nursing care, and then talk about interventions and collaborative management for patients with musculoskeletal problems. Muscular dystrophy, this is a significant issue. There are different types of muscular dystrophies, Duchenne's or different things like that. Realize that slow is more common in the adult world, where fast and rapid onset is going to be more in the pediatric realm. Both of these can be inherited by the X chromosome, so it impacts men more than women. Exact physiology is not known, but it could be related to poor blood flow to the muscle or disturbance in the nerve-muscle interaction. So primary clinical manifestation is muscle weakness, and then where this really goes bad is as it progresses. If you think about some of the muscles in your body, your diaphragm and your heart are both muscles, and so that causes the significance of this, especially later on in life, or later on in the disease progression. So intervention-wise, so pain management related to weakened muscles. We want to reinforce exercise taught in physical therapy, get genetic counseling, so that other family members might be aware of the risks, and then a lot of supportive care with this one. We don't have treatments to stop this or reverse this. It's just kind of a slow progression, usually in adults. Osteoporosis, I'm guessing most of you have heard of this one, but this is it's a chronic metabolic disease in which you get bone demineralization. You lose calcium and phosphorus, and then that causes fragile bones, and then usually leads into fractures. Within this, that's one of the first signs that you might see is a pathological fracture, especially of the hip. So, and basically what's going on is your body is reabsorbing the nutrients, especially the calcium and phosphorus, more so than it's building up the bone. And so you're going to see, fractures of the wrist, hip, and vertebral column. Primary is mostly common in postmenopausal women, and we believe that this is related to decreased estrogen. So risk factors: decreased calcium intake, deficient estrogen, and limited exercise. Secondary, of course, would be related to other disease processes in which you're leaching out your calcium and phosphorus salts. I have seen that with calcium or with cancer and different things like that. So physical assessment: attain your height and weight. The patient might be shorter, especially if it's impacting their spinal column. You might also see like kyphosis, in which you get significant change of their spinal cord. Often this is painful, and then especially if they get a pathological fracture, it's painful. So quality of life might be affected by pain, insomnia, depression, or phallophobia, which I don't know if that's true. Spelling or a true thing of this, but they are afraid of living in fear of falling. If they know that they've got weakened bones, if they know that they could have a broken hip if they fall, that is a real phobia. I'm not sure if that's the real term of it. So with that, we're going to do imaging. So DEXA scan, looking at the bone density, CTs, X-rays, those kind of situations. When they have pathological fractures, it's a question that I've heard from some of the orthopedic surgeons about, with these patients, did they fall and then break a hip, or did the hip break first and then that's why they fell? So it just kind of depends on how significant their osteoporosis is. So planning and implementation, so potential for fractures related to weak porous bone tissue, so we want to try to avoid falls, manage risk factors for falls, and then of course increase bone density. We've got different medications that we can provide for this, and increasing calcium and vitamin D in their diet. So, like I said, nutritional therapy, looking at calcium, vitamin D, avoiding alcohol and caffeine as much as possible. Exercise, especially some weight-bearing exercise, will increase bone density. We're looking at fall precautions, of course, and then, like I said, drug therapy. So, estrogen agonists or antagonists, biphosphonates to try and increase bone density, calcium and vitamin D, and calcitonin to try and increase that bone density. Now with this, we do want to do is get them into the home and keep them in the home as long as possible. And so they might need long-term care. if they were hospitalized, and even like, up until that point or beyond that point. So for good educational things, you can refer them onto the National Osteoporosis Foundation, and that would have different links for them for educational purposes and even for community. Osteomalacia is similar to this, but this is going to be more of a vitamin deficiency, especially of your vitamin D. You might also call this rickets. This is a softening of the bone in which you are deficient calcium phosphorus. So it's very similar, but your real cause is your vitamin D deficiency. And so we're seeing some of this more with, like I said, dietary changes, but a lack of sun exposure. We got into the mindset that sun is bad, you need to be covered up, you need to have sunscreen on at all times, and so some people are deficient on vitamin D because they're lacking sun exposure. So we can augment and supplement vitamin D, and so that's often what we will do in these cases. As we talk about osteoporosis and osteomalacia, realize that they're very similar. They both have got decreased bone mass and bone demineralization. This one's more of a lack of calcium. This one's more of a lack of vitamin D. Can get fractures, pseudo fractures of both. Talk about low calcium phosphate levels. Parathyroid hormones can leach out of the calcium out, and the vitamin D out. And then the alkane phosphatase might be high in our osteomalacia. Paget's disease, so this is a chronic metabolic disorder when you're constantly breaking down your bone and you're reforming it. And so with this, the bone density is impacted with this because it's so rapidly building that it just doesn't do it correctly, and so it's going to lead into weakness. And so these patients might have a history of fractures, might have a curvature of their spine, they're going to have pain, and then even their skull, because that gets remodeled as well, and you're going to have abnormal size and shape of that. So eventually this can lead into cancer because of, as it is getting broken down and reformed so rapidly, it's doing it incorrectly, and those cells can mitigate into cancer. Treatment, pain management, surgical erections if needed for joint replacements and spinal decompression, but there's not a lot that we can really do for this process, unfortunately. Bone tumors, so often these are asymptomatic, so you might see them as a finding of somebody finding a lump on one of their bones, or you get pathological fractures with this, causes unknown. Osteochondroma is the most common with this one. Can start in childhood, but can be at any age. And then often the femur and the tibia are the most involved with this. So physical pain is sometimes with this, and pathological fractures, as we said before, and of course that would cause pain. Might see it on imaging, x-rays, CTs, MRIs. Oftentimes what we do is treat the pain as needed and then surgically remove this. Could go in with radiology, and that's a possibility as well. Bone cancer, having this more aggressive. So this occurs in people aged 10 to 30 years old, so it's kind of younger adults, generally speaking. And then it can originate in other tissues and then metastasize to the bones, or it can go from the bone into other tissues. So osteosarcoma is the most common type of malignant bone tumor. Radiation therapy is the largest risk factor, so if they've had radiation therapy before, this can lead into the osteosarcomas. And unfortunately, treatment is palliative usually in these cases and not necessarily curative. So assessment, physicals, and imaging, so we talked about that before. Psychosocial, so good support system, and oftentimes they really feel a loss of control over their life, which is understandable, I believe. Laboratory, so we're monitoring alk phosphatase as probably well as calcium, vitamin D, and other bone mineralization. Diagnostic-wise, we'll biopsy that site and see what type of cancer it is. That way we can have appropriate treatment. That treatment can be chemotherapy, radiation, interventional radiology, or surgical resections, or even, I've seen amputations related to bone cancer. So self-management, so we really want to provide independence as much as possible, teach them how to do ADLs and mobility, pain management techniques, and then look at side effects of the medications and the treatment that we're using. If this is a more palliative type of situation, help prepare for death depending on the prognosis. Scoliosis is a curvature of the spine, often side to side or a lateral type of a transition. And so what you're having is vertebral rotate, so they spin a little bit and then they compress and you get this abnormal curvature. So just depends on how severe it is, the side effects that you're going to have, but back pain is common with this, but it could cause nerve impingement, and that could cause a whole host of problems from that site on down, including pain, bowel, bladder, muscle function, etc., etc. So with this one, so we're doing assessment-wise, so we can look as somebody bends forward. It says child in here because oftentimes we see scoliosis in an adolescent age. But you're seeing that there's an asymmetry between sides. Another big one is hip height discrepancies. So as you're having them bend over, you're seeing that one of the hips is higher than the other one. So diagnostic-wise, we're looking at x-rays, and then on that, it's got to be a significant curvature to try and do treatments and stuff like that. So treatment of that is going to be, best case would be a TLSO. That's a big brace that kind of looks like a corset, and it is hot and it's uncomfortable. Most people don't like it. Otherwise, if it's bad enough, we can do a surgical correction using rods. Gout, so severe systemic disease in which you get increased uric crystals, goes into the joints and causes pain and irritation and redness. One of the most common sites for this is right here on this joint of the toe, or the large toe. It gets red and inflamed and irritated. So what happens is you get that uric crystals in there, and it causes irritation. So how do we treat this? So this is a disorder of purine metabolism. So oftentimes we say increase fluids. Try to have a low purine diet. So that's going to say lower alcohol, especially like wines, low red meats, different things like that. It could be secondary to other causes. I've seen this related to chemotherapy and some of the side effects that can cause with an increased production of uric acid. Assessment, so swelling, inflammation, fever, malaise, it really hurts. Like people do not even want like a sheet on their foot or anything like that, or socks, because it just hurts that bad. Can cause pruritus, can cause renal stones as you get that increased uric acid throughout the whole body. So like I said before, treatment, low purine diet, high fluid intake, avoid alcohol, especially wine. And that's part of your low purine diet. And then if they're having an acute attack of gout, bed rest, have some flexion of the joint, and then heat or cold modalities might make it feel better. And then of course pain medicines to help out with that. So this completes this lecture. If you have any questions, please contact me.